Hi, welcome everybody to OT Echo. This week we have Jen Phillips presenting for us on weight bias and weight stigma. In the essence of time, I know we have a lot of content to get through. I'll pass it right over to her. If anybody has any questions, please feel free to interrupt or to put them in the chat. I will also watch that as well.
Thank you, Kelsey. Thank you everyone for being here. I'm excited to share on this topic. Just wanted to share a little bit about me. I teach at the Boston University Post-Professional OTD program, and I also teach at the BU Undergraduate Behavior and Health program for undergraduate studies. And then I work clinically in home care as well. And I volunteered for a little while for the University of Guyana, and that's how I met David and kind of got linked through this nice community. So thank you so much for having me. And as Kelsey said, there's a lot of content to go through today, but if we don't get it through it all, I definitely anticipate not getting through the video. I will be sure to share the slides and the resources with the video for today's presentation. So before we get started, I just want to do a brief content advisory. We will be talking about weight bias and weight stigma. So if you're not comfortable with any of the topics we're discussing today, you are welcome to leave at any point. We're going to go over obesity statistics and definitions. We'll look over weight bias and weight stigma, the difference between that, the impact of weight bias and weight stigma on patients, interventions to address weight bias and weight stigma in healthcare. There's a video as well as case studies that we will review together. So starting off with the definition of being overweight is defined of having a BMI of 25 or higher, and that's from the World Health Organization's definition. Obesity is defined of having a body mass index of 30 or higher. And then childhood obesity is defined of having a BMI for age of the 95th percentile or greater and being overweight as 85 to 95 percentiles. And then over the years, obesity has dramatically increased in the US as well as other countries around the world. From 1999 to 2000 to 2007, to 2018, it increased from 30.5% to 42.4%. And this is predicted to continue to rise over time.
Yeah.
And now, yes. Not only have rates of obesity increased, but also severe obesity in America has risen. And that has risen from 4.7% to 9.2%. And also adults have been affected by obesity, but also children, with 20% of children having obesity between the ages of 2 and 19. And in the US particularly, the incidence of obesity in children exceeds that of any other chronic condition. So as occupational therapists, we're likely to be working with children, adolescents, and adults with obesity. Yes, I see there's a question.
Are you showing us slides right now?
Yes, can you not see them?
I can't see them. I don't know if other people can. It might be on my part.
Oh.
I see you, but I don't see slides. I did before.
I'm able to see slides.
Okay, so it's my part. Thank you.
Sorry about that. During the pandemic, the COVID-19 pandemic, obesity was already established to be a comorbidity that could affect COVID more. But it was really proven during the COVID pandemic that people with obesity were more at risk of having complications from COVID. And then in the US here, people were considered a priority for vaccination if they had obesity. So just seeing the different ways that obesity can affect chronic conditions. In this case, it's COVID. And not only in the US, but the United Kingdom, where 50% of adults have obesity. Socioeconomic status is correlated with obesity. This could be due to lack of access to healthcare, lack to access of healthy food options. There's areas called food deserts where there's not a lot of availability of fresh produce, healthy food options, or areas such as parks or gyms that are accessible, impacting people with obesity. Childhood obesity is affected by socioeconomic status, with less prevalence found in households with higher education. So obesity prevalence is 18.9% among children and adolescents that are 2 to 19 years in the lowest income group, and 19.9% among those in the middle income group. And then 10.9% have obesity in the highest income group. So you could see here that there really is a disparity between SES status and obesity for children. And this is a graph from the CDC taken in 2021. I included a few graphs like this just to show the increase of obesity over the years. So you could see that the blue is overweight, the blue solid line, and this is for men and women. So the men is the solid line, women is the dotted line. So you could see that rates have kind of stabilized for obesity, or being overweight, but that obesity and severe obesity has increased for both populations over time. So you could see in the 1960s, it really was close to not very prevalent. And then over time, it has risen, and it's projected to continue to rise. Glad you're able to see the slides. Just saw that in the chat. And then this is the same graph with childhood obesity. So same thing here, we have different age groups, 12 to 19 being the highest rate of obesity, and 2 to 5 years old as well, showing a dramatic increase over time. And this is just a picture of obesity in the US, and it's depicted by color. So you could see that the highest rates of obesity being in Louisiana, Oklahoma, and West Virginia. That's at 40 to 45%. And then we see a lot of red and orange here, which is 35 to 40% and 30 to 35%. And then just a little bit of green. So in time, it's predicted for the US at least that these colors will likely change to all dark red, with obesity continuing to rise. So just wanted to give a brief overview of obesity and the increase it has had over time. And we're going to shift over to weight bias and weight stigma. So I just want you to think, we're going to have a pause and think moment here. I just want you to think of a time to yourself when you went to a healthcare appointment and felt stigma or bias towards you. How did it make you feel towards the healthcare practitioner? How did it make you feel about yourself? And no need to kind of raise your hand and share these things. I just want you to kind of think about that for a moment. So weight bias is defined by the World Obesity Federation as referring to the negative ideologies associated with obesity. So this is often ingrained in our society through media, the public, or shows. Examples might include being lazy, having an unhealthy lifestyle, or a poor work ethic. So this is just something that often is ingrained in us with bias. Weight stigma is different, where it's defined as having discriminatory acts and ideologies targeted towards individuals because of their weight and size. So this is taking actual actions towards someone just based on their size. So this might include negative comments, unfair treatment, lack of healthcare time, which we'll get into later in the slides, and the healthcare environment not being accommodating and not having proper equipment or supplies. So this is weight stigma. So weight bias is kind of like a thought you might have in your head. Let's say you see somebody walking down the street and you have a thought in your head. weight stigma would be you acting out against that person walking down the street and perhaps calling them a name or doing an actual act. And that's the difference between weight bias and weight stigma. And this is just a little bit more about the difference between the two. Now we're going to go a little bit into what the research says. So this is all about weight bias and weight stigma in healthcare predominantly. So I did a full review of several studies, and they all produce similar conclusions. So there was 21 studies were reviewed to evaluate the impact of weight bias and weight stigma on healthcare utilization for individuals with obesity. And within the US, weight bias was included within the top 4 most common forms of discrimination for adults. Over the past 10 years, it has increased by 66% in many settings, and this including healthcare. So 66% is really a dramatic rise. We could say it might be associated with the rise of obesity over time, but that is a pretty significant percentage. Healthcare professionals have been documented to have negative views about clients with obesity. And we'll go further into healthcare professionals working with clients with obesity. A lot of the time, during some studies, it was found that healthcare professionals just assume the cause of obesity is to be within the patient themselves. So often people with obesity are being blamed for their prognosis or their health because healthcare professionals are finding that they feel like it's kind of their fault. And this has been correlated with condescending advice towards the patients on how to manage their weight. Lack of empathy has been found throughout clients with obesity. Clients with obesity have reported this from healthcare professionals. They have found that they have less healthcare contact time with the patient, assume that all healthcare issues are related to the person's weight. There's less emotional understanding, disrespectful comments, and being perceived as being less adherent to medical advice or treatments. Another review was conducted on weight bias and weight stigma in healthcare professionals. And it was documented that healthcare professionals were the second most common form of weight stigma. And this was documented to be higher among healthcare students. So it's really important that we're educating students while they're receiving their education so that we could kind of get ahead of the weight bias and weight stigma. And people with obesity or being overweight reported that they were viewed by healthcare professionals as a failure, lazy, or unmotivated. And then a manuscript about weight bias and weight stigma in healthcare was published, and people with obesity ranked physicians second after family members for weight bias. So especially in pediatrics, a lot of weight bias and weight stigma might come from a family member first. And just being that physicians are the second after family members is concerning. Medical students reported their faculty members having an associated bias when working with clients with obesity, and they reported the bias within the classroom. And then this was perhaps carried over to their practice in the field. Third-year medical students were found to provide less patient-centered care when working with patients with obesity as well. In Germany, 47 general practitioners, so physicians, were evaluated on their own perceptions of patients with obesity. And every practitioner, so every 47 people in the study, found to have moderate to high weight stigma towards clients with obesity. Clients with obesity were less likely to be referred to specialists as well. And then there's several studies. When I did the research, a lot of studies came up on maternal health and maternal obesity, and a lot of qualitative information came from these studies. And patients described that the health experience during this time of being pregnant and having obesity to be filled with judgment, persistent with weight stigma, and lacking trust in healthcare professionals. Patients also expressed that healthcare professionals appeared to have a lack of training on how to work with people with obesity. A lot of other information from those studies included, if the mother was had obesity, they were often blaming any health issues of the baby on the mother and her health. So really unfortunate during a fragile time when you're wanting to trust your healthcare professionals, and these studies documented that there was a lack of trust. We're going to have another pause and think moment. I want you to think about a time you attended a healthcare appointment. Were there a variety of seating options available? Were there different sized blood pressure cuffs? Have you worked with a patient or client before who didn't have appropriate equipment? So just thinking about that, or, I've gone to appointments recently and I've seen different size seating options available, but that's been relatively new within the past few years. So the physical environment of our healthcare environment has multiple forms of bias, and this includes having a lack of variety of seating options, one-size blood pressure cuffs and not having bariatric blood pressure cuffs, gowns that are not accommodating, a lack of bariatric equipment, and then the overall routine of how a patient is being weighed was documented a lot in the research, and how this really should change to make it a more accepting environment. So how do all these things impact a client with obesity? So we as occupational therapists, we're often working with clients in intimate moments such as bathing or dressing. And, it's good for us to have knowledge of how a client with obesity might be feeling after going through a healthcare episode where they feel they might have had bias or stigma towards them. So it was documented that clients reported emotional distress, refusal of care from healthcare professionals, maladaptive eating behaviors increased after experiencing weight bias or weight stigma. They had an overall lack of engagement in physical activity. Increased mortality rates were documented, an increased risk of mood disorders, increased stress. Often they're misdiagnosed because often healthcare professionals might be blaming their weight rather than kind of looking into other issues that might be affecting them. They may have a low trust in medical providers. They may have anxiety and depression and suicidal ideation, low self-esteem, and poor health outcomes. They're more likely to have an increased risk of developing obesity. After going to a healthcare appointment that was stigmatizing or had bias, it's been documented that increased food intake to kind of cope with this was participated in. Emotional and binge eating as coping strategies to combat this stigma. Weight bias internalization, or WBI, is defined as having self-stigma or self-stereotyping and self-de-evaluation due to one's body weight. So this was documented as being increased after a healthcare encounter. Clients expressed that if they are receiving interventions prescribed by a healthcare provider that was stigmatizing, they're less likely to engage in the intervention. So kind of doing the opposite of what we hope to do for our clients, and trying to encourage things that better their health. This weight bias and stigma is actually doing the opposite. In Germany, it was rated that the care of the patients with obesity was below average. Documented also that individuals with obesity receive less healthcare contact time, and therefore they're at a disadvantage for quality medical care. Patients with obesity may cancel appointments or avoid the healthcare environment, leading to an exacerbation of healthcare problems and a delay in care. So how do we think this will impact the future of healthcare? So if clients with obesity are not feeling comfortable to go to appointments, then there might be an exacerbation of an associated health condition, and there might be unexpected hospitalizations. So just thinking about that and putting a taxing the healthcare environment just being taxed due to this. So several interventions were documented, but there would have to be more. Jones and Forehand, who is well documented, an occupational therapist in Canada, has done a lot of her studies for OT and obesity. And they developed an 8-hour interactive seminar for PTs and OTs in Canada to see if they could kind of try to combat this weight bias and weight stigma. And this was specifically with joint replacement. So they found that the therapists changed their view on the causes of obesity and it not being at fault of the individual, which was good. But it was documented that some of the training contributed to the bias and stigmas of the therapists. So they were hoping to decrease the bias and stigmas, but the training actually kind of contributed to this. This may have been done to the format and how participants were kind of talking about their experiences working with clients with obesity, but not the results that they were hoping for. So this study concluded that more intervention approaches need to be documented to see what's most successful. What we can do, simple things that we could do right now, we can use people first language. So say patient with obesity rather than obese patient. Use terms such as healthier weight or high weight, especially when regarding children. Studies were done with parents' perceptions of how their child were addressed with healthcare providers, and they did not prefer the term obese or obesity. If you're in an opportunity to talk about weight, if the patient or client would like to talk about their weight, it should be done in an empathetic and supportive environment. We need to promote empathy and weight-inclusive approaches in our treatments. We need to recognize our own weight bias and weight stigma. And it was documented that a positive interaction with a healthcare provider was viewed as more favorable, and the patient was more likely to participate in the intervention. So trying to promote positive experiences, that's something we can do as OTs to allow the patient to kind of have a better relationship with healthcare and interacting with healthcare professionals. Trying to promote a more accommodating healthcare environment. I worked with a patient before. We didn't have a bariatric blood pressure cuff, but I did a blood pressure cuff on her wrist instead, and I was able to get a good reading that way, rather than having her feel like we didn't have the equipment available to her. Looking at the size of the gowns, looking at chairs, beds, wheelchairs, or any type of DMA. Looking at obesity as a disease, this is associated with less stigmatizing behaviors, more empathy, and less blame towards the individual. And trying to educate healthcare professionals and students on these factors beyond lifestyle that are contributing to obesity, like genetics and socioeconomic status. Healthcare providers have mentioned that they would like to receive more training on how to work with patients with obesity and have positive conversations. So we should be providing education while healthcare providers are receiving their education. Having opportunities to practice and observe non-stigmatizing interactions as well, especially when we're receiving our education. And this is the video. It's about 6 minutes long. I'm thinking we probably don't have time for it before the case study and breakout rooms. I see a couple things in the chat. Oh, I'm sorry. Yes, durable medical equipment. Thank you. What do you think, Kelsey?
I think if it's 6 minutes, I think you can get it in. Yeah.
Here, I'm just log out of this. Need to pull it up for a minute, then I'll reshare my screen.
Melissa Kretschmer is a social worker in Philadelphia. A big part of her job is listening to people, so she began to wonder why doctors had such a hard time listening to her. I was coming in with issues and nothing was getting resolved. Every time I went to the doctor, it was like, you need to lose weight, like you need to eat healthier. And I'm like, I do eat well, I eat well, I move my body. This is still happening. But I feel like you're not really believed when you say that. Melissa felt that no matter her medical problem, doctors always focused on her weight, and that society did too. She felt this fixation was making her less healthy, not more. Usually going to the doctor meant feeling like a lot of shame about my body. For me, that, and I think for a lot of people, like that just leads to like this pathway to disordered eating and hating yourself and just feeling like you're not worth care and love and everything. Melissa's story isn't uncommon, says Fatima Cody Stanford, an obesity specialist at Massachusetts General Hospital.
I think it goes back to a lack of understanding. And that lack of understanding regarding obesity is on the part of all individuals, physicians, other healthcare providers, the general population. They think it's a lifestyle choice. Unfortunately, this is completely false. There are over probably 100 factors that contribute to body size, the bacteria in one's gut, medications that lead to weight gain. And the biggest factor is genetics. If we have parents that have obesity, the likelihood that we ourselves will have obesity is on the order of somewhere between 55 to 85%. That is even with optimal behaviors. Many of the patients I see, by the time they finally make it to me, have diets that are better than most people, exercising more than most people, but still have excess weight.
These misconceptions about weight can lead to stigma and discrimination, which have been associated with harmful impacts on patient health.
Weight bias needs to be picked up as a major threat to the health of our public. It actually leads to increase in stress, increase in blood pressure. It can raise their average blood sugar, which predisposes them to getting diabetes. It leads to depression. It leads to anxiety. And unfortunately, it can lead to higher rates of suicide.
It also leads to lower quality medical care for heavier patients, Stanford says. She sees the damage of weight stigma in nearly every person who walks through her door, recalling that one middle-aged patient even brought his mother to their first visit.
He needed his mom to convince me, the doctor, because that's what he had to do his whole life, that what he was saying about his activity and things were indeed true.
Stanford ultimately helped this patient reach a weight that worked better for him. But, she says, if he walked into another doctor's office, he'd likely be told that he needs to lose all of the weight.
If you knew nothing about him and he walked in your office at 300 pounds, the first thing that would probably come out of the mouth of the doctor or other healthcare providers, you need to lose weight. Not recognizing he's lost 250 pounds. He's been able to maintain it. He has no other health risk factors now. He's able to do everything that he wants to do. So, are we listening to our patients? Are we recognizing that we're not one size fits all? I don't need to get him to a certain number on the scale. Like I tell my patients, whatever is the happiest, healthiest weight for you.
When Vicki Borgia co-founded her own primary care practice in Philadelphia, she found that many of her higher weight patients shared similar negative experiences with the medical community.
They have all been on multiple diets. They have all lost significant amounts of weight and then gained back more. They have all been shamed in the medical system at some point, and so don't go back. They actually have physical trauma from our medical system.
Borgia chose to create a weight-inclusive practice, from exam tables and blood pressure cuffs made for larger bodies, to the way she talks with patients about weight.
Weight should be a factor, of course, but it should not be the only factor. The only time really I talk about weight with people is when we talk about weight stigma and their experiences and how that shapes things. Because what I talk about is health.
Borgia works in depth with each of her patients to determine their health needs. She may focus on measures such as blood pressure or hormone levels, or she may help a patient with their sleep, strength, eating habits, or stress management.
I'm talking to people, figuring out what their goals are, and then trying to make that happen in whatever way we can.
After years of feeling unheard by her doctors, Melissa decided to find a physician who took a different approach.
I wanted someone who would listen to what I actually need and actually look at me as a human being, which I know sounds wild to say, but I've had a lot of experience where that wasn't the case.
Things changed when Melissa joined Borgia's practice.
I feel a lot healthier. I have my blood sugar managed in a much better way. I'm not doing any sort of disordered eating behaviors. So I think it's been a huge change in terms of just feeling better about myself and wanting to take care of myself.
Patients are going to live in this body the rest of their lives. And so we want to make it as healthy as possible and give people lives that they find meaning in. It's, it's about sustainable lifestyle that will bring you joy in life, not just make you skinny.
Okay. So I think do you want me to share the case study?
That'd be great. Jen, are you able to share your screen with the case study? You can go ahead and read it through, and then we'll be sending off into breakout rooms.
Okay, sure. Okay, so Carl is a 58-year-old male who just underwent bariatric surgery and is being seen in the step-down unit at the hospital. His comorbidities are as follows: morbid obesity, depression, binge eating disorder, night eating syndrome, hypertension, sleep apnea, gallbladder disease, type 2 diabetes. He currently has a stage 2 sacral wound. He lives alone in an apartment building complex and has a pet pug. His prior level of function was that he could transfer from his wheelchair to his bed and/or toilet with use of a walker, but he was not safe in doing so. He works as a computer designer and recently had to stop due to medical limitations. He has a supportive sister who is available to assist him, but she is highly anxious about his needs and how he will continue living alone to support himself. When you approach him at his hospital bed, he is unengaged and self-conscious as the current gown he is wearing is too small for him. He does not want to bathe or get up today because he feels he does not have the equipment he needs to do so. And then the questions on the next slide are, as an occupational therapist, how would you approach Carl and get him to participate in OT? Before seeing Carl, what is something that you could do before to prepare for your OT session? And what would you recommend for Carl to facilitate a safe discharge home?
I was muted. Thank you, Jen, for that. Everyone's been assigned to a breakout room. I will open them up in a second. Does anyone have any questions before we go off? And if not, no worries at all. If anything comes up during the breakout rooms, note it as well, and we can come back to other questions. Everybody will have about 15 minutes in the breakout rooms today.
We'll head off to the breakout rooms, and we have some questions on the way back that we'll have answered with Jen. Wonderful. So we come back from our breakout rooms after participating and discussing a case study with 3 key questions. I encourage you all to participate as best that you feel most comfortable. We'll have Jen also contribute her thoughts with these questions as well. I also just want to commend us and this group. I can't believe how many people are signed on today. I believe this is one of our largest attended topics this year. So just kudos to all, and thank you, Jen, again for joining us today. So let's pitch off into our questions. You learned about Carl, who's a 58-year-old male who underwent bariatric surgery with a lot of different environmental and occupational concerns. Your very first question I'll pose back to the group is, as an occupational therapy practitioner, how would you approach Carl to get him to even participate in occupational therapy? What were some things that your group discussed?
The first point that our group brought up was the fact that he has a pug, and he's obviously very fond of the pug. So one thing you could do would be have discussions about how he cares for it and the importance of it in his life, and how what things he needs to be able to do to be able to take care of his pug.
Thanks, David. And Jen, I'll actually have you comment, validate, or continue the conversation with each of these questions.
Okay.
Anyone else have, what else could we do to get?
Good evening. So in my group, we have discussed building rapport with, and also the first thing is to address this concern on the gown, get him an appropriate gown to put on, and also we talked about getting the right equipment for transfer and taking off pressure from the wound area and advocating his needs.
Great ideas. Something that I've done before too regarding the gown is I've if like there wasn't a bariatric gown available or a larger gown, I've tied two gowns together and use that instead. So another way to kind of approach it, and maybe think about doing that before you see him.
Thank you so much, Tulu and David, for your contributions. Maybe we'll hear from one more group. And thank you, Claudia.
Yeah, so our group also we felt like that first session, clarify what he thinks he needs and kind of lean in and be curious. What does he hope to accomplish in therapy? Where is he at in terms of thinking about his own sense of agency and ability? So in addition to things like thinking about maybe return to work interventions, do some goal setting with him for when he returns home.
Fantastic.
Yes, is it okay for me to also say something about our group?
Sure, yeah.
Yeah, so our group discussed about, first of all, working on an assessment with Carl so that we can determine what are the goals, what are the interests, what hobbies, and the strengths that we have. So we talked about the size of the gown, and then maybe providing him with necessary linen in the care. Then the accommodating environment in which he can perform his ideals, and maybe educating the caretaker, the sister, on what to do, and engaging the family, then being empathetic and providing client-centered treatment. Thank you.
Thank you.
Awesome. Thank you so much for these contributions. We'll go ahead and continue on with maybe one more of these questions. And then I also want to address the questions in the chat box too, that are really specific to this unique population, Jennifer. So let's kind of go with question 2. Before you even see Carl, what is something that you could do to prepare for your OT session? I love that. Preparation is so important for safety and inclusion.
So I'm going to kind of go quick on this too, because our group actually had all the same for one, but really coming prepared with equipment, whether it's ADL equipment, but also in the room, making sure whether there's a trapeze bar to help with repositioning, or an overhead Hoyer lift of some sort, right? Because sometimes if a client, a patient with obesity might be one of the patients, unfortunately, due to that biased stigmatism might not be removed out of bed frequently because it might take more people to do so. So kind of making sure that the environment is set up so that if therapy does go into work with the patient, then the people there, staff can safely transfer and maneuver the patient, making sure there's a bariatric bedside commode. Let me make sure I got everything as far as equipment and really making sure we address the patient's needs, but also that the staff is comfortable with working with the patient as well.
That's great.
Jennifer, yeah, you give such like a lovely encompassing so many different things, Jennifer, you're thinking about the environment and the task and the person. Jen Phillips, any other kind of comments related to that one group? I think we'll actually have to stick there based on our timing.
Yeah, I mean, I think it's really great that you thought about the other staff members as well, and the lack of change of position, and that's really common too. So thinking about, you know, training others or getting them on the same path as you.
Thank you so much,
Yeah,
Jennifer.
our group we also
Oh, go ahead. We'll hear from one more group. Go ahead.
So our group discussed about the carer, getting a carer or social workers involved, as well as keeping the session like low key and ensuring to start slowly and gently, discussing the strategies for the wound care, as well as bed exercises, in addition to the equipment and all that has been mentioned by other groups. Thank you.
in our group we also discussed something that we can do before we see him, and we think before, you know, that will be our first time to see the client, and we say that the only thing we have to do is to first gather the information about the clients. You know, if you're seeing the client, you have to leave you the medical records, you familiarize with his medical history. You know, they did surgery, you have to know the details more about that, the wound, the status of the wound. Another thing we said, we also need to see if there is a recent assessment that should have been carried out by other care providers, so that we have detailed information. And another thing we discussed is that we think it's better to talk to nursing staff, you know, about it, and we obtain the current information about his condition and the pain levels if it is there, and any recent changes in his status. We also said that we can also gather necessary equipment, and we said some of them we can go ahead with bariatric chair, maybe transfer aids, and any other assistive devices that we might need. So thank you. That's what we discussed in our group on this second question.
Awesome. Thank you so much. I think one of the formative elements of ECHO is really being able to have these conversations around case studies and reflection of our role with the OT scope with really unique opportunities. And so that includes Jen. Jen, I want to have you close here with one final question, and that is maybe any key takeaways or aha moments that you would really like this group to leave with related to your experience or people's future experience in treating clients with obesity.
Yes, thank you. I would say why I started to begin working on this topic was when I was working in a skilled nursing facility or a nursing home, and we accepted a patient who was a bariatric patient, and we didn't have any of the equipment needed for her. And I think somebody put in the chat about how the patient might feel about having to have a lot of assistance to do things within the healthcare environment. And this is exactly why I went into it, because she was so uncomfortable. She was really embarrassed about all the help she needed, and healthcare workers were making comments outside of the room. And I had so much empathy for her, and she did eventually get discharged, but my experience working with her really is what precipitated everything. So I think the key takeaway would be coming from a place of empathy and understanding, and knowing that a patient with obesity might have some traumas associated from past healthcare experiences, and trying to be the change in our healthcare environment for that. And as OTs, we're all leaders to do that. So I encourage you to all be leaders with that.
Thank you so much, Jen. We do see that it is 3:02, so anybody that does need to hop off, we thank you again. If you have any questions, please let us know. Jen, do you mind if anybody emails you if they have any questions as well?
Oh, sure. I would love to hear from anyone. Do you want me to put my email in the chat or?
That would be great if you can. Perfect. Okay. Thank you, everybody.
Thank you.
Thank you, Jennifer.